So we are grateful to NOVA Biomedical, a group of new friends that I had the chance to meet recently. Also thanks to the collaboration of Professor Tiago Reis from Brasilia, who was one of our fellows. And we're going to listen an interesting topic, which is the possibility to really optimize electrolytes management during CRRT, but in general in intensive care, and the possibility to have access to more information will certainly make our care better. So the first talk will be a real point of care creatinine meters opens big possibilities, and we have Rubens Escobar Lodi, Director of Medical and Scientific Affairs in Latin America of NOVA Biomedical. Please. Okay. So we have Tiago speaking first?
That's it.
Okay. I'm sorry. I had the wrong order. So we have Tiago Reis, which is also a good friend of us because spent some time in IRIV and is now back to Brasilia. Please, Tiago.
Thanks, Professor, for the introduction. I'd like to thank NOVA Biomedical for sponsoring this activity. And there's a lot of information here, so let's rush through the slides. So how the critical care analyzer enhances patient safety, circuit patency, and therapy effectiveness, and why ionized magnesium should not be left behind. So these are my conflicts of interest. Efficacy and safety of regional citrate anticoagulation. We will cover ionized calcium in CRT, both systemic and post-future. CRT imbalances, hypophosphatemia, hypokalemia, hypomagnesemia, magnesium ionized versus total magnesium, hypomagnesemia, and clinical outcomes, and the point of care analyzer. So citrate chelates cations, of course, calcium, and hinders the coagulation cascade, but also chelates magnesium. So this trial compared two anticoagulation strategies in CRT, citrate versus heparin. This was 0.5 sodium citrate, and the results demonstrated that future lifespan is better with citrate, 47 hours versus 26 hours. Importantly, less bleeding with citrate, 5% versus 17%. Citrate is safe, so after 30 minutes of its discontinuation, the blood levels return to baseline as well as for ionized calcium. And in this analysis, more than 1,000 patients were analyzed, were on CRT with citrate. Those patients that had hyperlactatemia and continued hyperlactatemia, they had a chance of having citrate accumulation of 6%, whereas those with normal lactate or non-sustained hyperlactatemia had a chance of less than 3% of having citrate accumulation. And above all that, citrate only hinders the coagulation cascade when the concentration of ionized calcium is below 0.4. And that does not occur in the patient, only in the circuit. So it's safe to use citrate even in conditions such as intracerebral hemorrhage. And this is the representation of the circuit. So imagine that the blood is coming here from left to right. We measure systemic ionized calcium here before. Then we have the citrate, blood pump, blood goes through the dialyzer, and then we measure here the post-future ionized calcium. The range we aim is between 0.25 to 0.35. Usually we do that every 6 hours. Here is the real representation of the CRT screen. So the blood again coming from left to right, then gets citrate, goes through the blood pump, and then dialyzer. I'd like to stress here that the citrate we use does not have potassium, neither phosphate, neither magnesium, and the flow here is 1200 mLs per hour. So almost in this dose for a patient from 80 to 100 kilos of 30 mLs kilograms per hour, almost half of the dose is with a solution without magnesium, without phosphate. So the additional dose comes from the dialysate, which has potassium, has magnesium, bike, and also phosphate, 1200 mLs per hour, and then we use 300 mLs per hour just to create a vortex here in the bubble trap and avoid coagulation then in the bubble trap. Finally, there is calcium compensation. Okay, so we are prone to develop hypophosphatemia, hypomagnesemia, and hypokalemia. And how to assess the concentration of the electrolyte, in this case potassium, that the patient will be exposed to. So it's the weighted arithmetic mean to estimate that. In this case, potassium. So we need to know the concentration of potassium in the solution for citrate plus times citrate flow plus concentration of potassium in the dialysate times dialysate flow, and finally concentration of potassium in the replacement solution times replacement flow, all that divided by the flows of each of those solutions. So in this case here, as I've mentioned here in the left, almost half of the dose is with a solution without potassium, and we can estimate that the final concentration of potassium that this patient will be exposed to is only 2.5 mLs per liter. So this patient will certainly develop hypokalemia, and you have to replace that. Magnesium, the way calcium is, works in the ionized form. Roughly 2/3 of magnesium are ionized, and 1/3 bound to proteins or complex with other salts. When you do CRRT with citrate, almost 30% of that previously ionized magnesium now is chelated with citrate, and it's not anymore biologically active. So in this study done in Czech, they were measuring ionized concentration of calcium and ionized concentration of magnesium before filter and after the filter. And they found that there is a perfect correlation between the ionized calcium here in the x-axis and also the ionized post-filter magnesium in the y-axis. So a linear, perfect linear correlation. The same goes for the reduction when you compare pre-filter ionized calcium versus post-filter ionized calcium, and then the same pre-filter ionized magnesium and post-filter ionized magnesium. So I'll take a point here, like when you have a 68% reduction in ionized calcium here in the x-axis, you go up here and then you have a 68% reduction in ionized magnesium. So they both behave the same, they are divalent cations. So how would be for magnesium the concentration that the patient is exposed to concerning magnesium? So the same thing, the solution here does not have magnesium, so almost of the dose is without magnesium. Then we have the dialysate, and finally replacement solution. Both of them have magnesium, but it's not enough because the total magnesium concentration that this patient will be exposed to is 0.42. If the total concentration is low, of course the ionized fraction will also be low. We know that there is a linear correlation from ionized magnesium to total magnesium in critically ill patients. That's fine, but that not occurs in patients critically ill undergoing CRRT with regional citrate anticoagulation. And that's the point I want to stress. So in this study in the Netherlands with 92 patients, here in the x-axis we have total magnesium concentrations, and here in the y-axis we have ionized magnesium concentration. These darker areas, they represent the normal range both for total and for ionized magnesium. The circles represent patients in the critically ill unit with not undergoing CRRT, and the squares patients undergoing CRRT. We can see that in patients not undergoing CRRT, the circles, if you have normal total magnesium, then you have normal ionized magnesium. That's fine, perfect. However, in patients undergoing CRRT, the squares here, all those patients here, if you only measure total magnesium, which is our reality, we use the Zillidio Blue method, so we only have access to total magnesium, you think they are doing fine, but see, they have low ionized magnesium concentrations. So the point here is that this analyzer helps you to identify patients that have truly hypomagnesemia. This trial in Thailand, they enrolled 14 patients, 7 with acute liver failure and 7 with acute on chronic liver failure. Here in the y-axis you have time, and in the x-axis you have time, and the y-axis you have ionized magnesium concentration. From the baseline, those patients with acute and chronic liver failure, they had lower concentration of ionized magnesium, and when you start CRT with citrate, there is a reduction both in the group with acute liver failure and acute and chronic liver failure. After 2 hours of treatment, citrate infusion was stopped and CRT was continued. And you can see that it takes almost 60 minutes, 1 hour, so that the concentration of ionized magnesium returns to baseline after citrate discontinuation. I've mentioned in the first slides that it took like 30 minutes, but again, these patients here, they have liver impairment, so it takes longer, but anyways, not that long. In this trial from Brazil, it was a observational cohort with 200 patients. 118 developed AKI and 114 did not develop AKI. Concerning hypomagnesemia, in the group that developed AKI, the percentage was 47%. The group that did not develop AKI, 62% with no significant difference. However, when we look at the patients that, the subgroup here that had AKI, those that recovered in that group, only 31% had hypomagnesemia, whereas 70% in the group that had persistent AKI had hypomagnesemia. So more hypomagnesemia in the group with persistent AKI. In this trial in Belgium with 400 patients, all the patients that were admitted to the ICU had their ionized magnesium concentration measured. So 14% of them had hypermagnesemia, 68% normal, and 18% hypomagnesemia. Those patients that developed hypomagnesemia in the course of the stay in the ICU, so they were 23, they had higher Apache 2 scores, higher SOFA score, were more prone to have septic shock, had longer ICU stays, and higher mortality. And finally, this was published 2 weeks ago, a retrospective cohort from Korea, in which they analyzed almost 10,000 patients undergoing cardiac surgery from 2006 to 2020. And they divided the concentrations of ionized magnesium in 4 quartiles, and it was demonstrated that the patients with lower concentrations of ionized magnesium were more prone to develop AKI and also AKI 3D, requiring uterine replacement therapy. For other outcomes, the secondary outcomes like mortality, ICU stay, and length of hospitalization, it was a stepwise increase in quartiles. It means that those patients with lower ionized magnesium had a higher chance of developing these outcomes. When you go to the second quartile, it was higher than the third, and it was higher than the fourth. Importantly, correlation is not causation. So was this cat responsible for this, and this bird for this? So this, I've presented observational studies, so no interventions were carried out trying to correct hypomagnesemia and change outcomes, but we need to keep this in mind. Finally, so the point-of-care analyzer allows the identification of ionized hypomagnesemia. Nowadays, we cannot identify that. Fewer time periods of CRT circuit with ionized calcium above 0.35. So if you identify that in 1 minute instead of 1 to 2 hours, which is the time that you take to get that from the lab, you can act and increase your citrate so that your ionized calcium concentration post-filter is in the range that you want. At the same time, you have fewer time periods of CRT circuit below 0.25, and you don't need to work with calcium, ionized calcium below 0.25. So there is less citrate consumption and citrate wasting. And finally, you have timely correction of other cations, such as ionized magnesium, potassium, sodium, and bicarb. So thank you so much, and I pass to Rubens. Thank you.
Thank you very much. Thank you very much, Tiago. We will have a discussion at the end. We are now having further presentation on this topic, so please proceed.
Well, welcome everybody. Let's go. So I will be talking about, of course, creatinine in point of care. In my point of view, point of care devices changes our relation with patients. And of course, point-of-care devices are around us for a long time. We can remember Dr. McCoy using their point-of-care devices in Star Trek, but maybe not in the early days, but AKG isn't point-of-care device. This one is a point-of-care device also. Of course, I have some remarks about how it can record or documented exam, but it's a point-of-care devices. Point-of-care ultrasound is a point-of-care. And it's replacing the stethoscope in many ways. But what is about point-of-care devices in vitro diagnosis? This changes everything. Of course, we are with point-of-care devices in vitro diagnosis for a long time. We have to remember that from 1972 was invented the glucose meters by Anton Clemens, is an engineer, and at that time is a kilo and almost a kilo and a half weights the point-of-care device. But after that, little changes. The point-of-care device is not meant to replace big laboratories. It's not meant to replace large volume labs. So probably you are wondering where the point-of-care devices can enter in our line of care. The point-of-care device enters where time is important. Enter where the blood volume is important. Enter where the patient experience is important. And most of all, enters where the laboratory doesn't reach. This is the important. The first place that the first place that we are talking about, of course, is medical imaging. In every guideline, they are said you have to determine the risk before procedure. We know about contrast-induced nephropathy; it's important, but the imaging center is a hurry-up center. So we have this paper over here, and it said that the patients are coming from trauma in the ER and going to the CT scan. And the main result over here is that the average time from the physicians to get the result is 11 minutes for the point of care, from 70-80 minutes from the central lab. But I think, in my point of view, the main result is that only 16% of the patients with the central lab laboratory arm get a CT scan with the actual this creatinine result, the glomerular filtration rate result. In 96% of the patients get at the CT scan, get their GFR before any contrast. This is very important. And I used to say that this is the difference between the long and the short arch of diagnostics. What's the long arch of diagnostics? The long arch of diagnostics is what we are well used. You have to order an exam, the guy from laboratory comes and draw the blood are sent to laboratory, go to the centrifuge machine, and put it in an analyzer, get the computer, and when your nurse has time to do so, check for the result. The short arch of diagnostics is what we have been doing with the glucose meters. You ask for the result, the nurse go get the gadget, puncture the finger of the patient, and after 1 minute, 30 seconds, get the results and show Dr. Rubens the result is 64 ml per minute. This has changed everything. And we have to do that because, in fact, contrast-induced nephropathy is not only a disease burden, a AKI burden, it's a cost burden also. A contrast-induced nephropathy can cost almost $12,000. And it's worth to do tests using contrast. But when we are looking in imaging, medical imaging, it's not only related to ionized contrast. It's about gadolinium also. There's mainly two groups of gadolinium nowadays. One, there's associated with NSF, nephrogenic fibrosis, and another group without NSF. You can say, I use only gadolinium without NSF risks. Okay, but mainly the gadolinium without NSF risk is more costly than the other ones. So ASR, American College of Radiology, made some guidelines to use the gadolinium that has most NSF adverse events. So one of the guidelines says you have to get the EGFR at least 2 days, prior to the ESM. Normally our patient will do not do that, especially if it's outpatient. So doing point-of-care analyzer with gadolinium, you can have the chance to choose the right gadolinium, low cost or more budget, or my high cost gadolinium, and have this cost issue if you have less than 45 ml per minute glomerular filtration rate. Other time situation is preoperative moment. In preoperative moment, we have the chance to find out the GFR of the patient. And we know that GFR is a prognosis in surgery. It's prognosis in short-term mortality, in long-term mortality. It's prognosis even in minor complications of the surgeries. So if you have this GFR before the surgery, you can address better the risk of your patients before the surgery. But there's a place outside the hospital that has a big opportunity for point-of-care devices like the creatinine, the pharmacy, where time is important because the customer over there don't want to wait so much. They want their medication, and the laboratory doesn't read. Of course, we know that nephrotoxicity is all around us, and we know that's a very range of risk factors for them. But one of the most important of them is renal failure. 60 ml per minute is as a threshold of renal failure will guide you to adjust medication, avoid some medications. The main problem is that the patients over there in the community pharmacy doesn't know that he has kidney dysfunction. In this paper over here, point-of-care devices were placed in the hands of the pharmacist, and every patient asking for a drug potentially with a potential nephrotoxicity was measured the creatinine. And what happens is that 11.5% of these patients didn't know they have less than 60 ml per minute of glomerular filtration rate, and probably the medication has to be adjusted or avoided in order to prevent AKI. This is very important. And we have another experience. The experience with the PrEP, the pre-exposure medication. We know that the pre-exposure medication, antiviral pre-exposure medications, is very important nowadays. This is a program that are being implemented all around the world. But we know already that some of these medications have some nephrotoxicity issues, and we have to adjust this medication. But in fact, most of the population who will reach for these medications are not prone to collect blood samples or doing a checkup. So this is a problem in this program. In Brazil, in São Paulo, we have this health department program over here that offers these drugs, pre-ep exposure medication, but they test the risk patients, every risk patients, in creatinine with the point of care. We can see at the right side before delivering the PrEP medication. And if the patient has a certain threshold of level of glomerular filtration rate or creatinine, they will refer this patient to a nephrologist, to a clinician in the nearby health unit. This is very important to prevent what this medication can do in nephrotoxicity. So there's another moment that we have certain uncertainty, is the first nephrologist consultation. We are nephrologists, and we know that we have several different slopes after an aggression of loss of kidney function. And one of our jobs is to push the patients at the best slope possible. So even in the health patients, we have these slopes. The main thing is that the cardiologists, I used to compare with them, the cardiologists use point of care for a long time. So normally when you enter a cardiologist office, the first thing you will do is a EKG. And when you enter, you are in front of the cardiologist, the cardiologist has the most actual photo of your heart at that moment. And this is normally, then when you face your patient in your nephrology office, the patient brings 3 months ago, 6 months ago, creatinine exam, say, doctor, how I am? With this 6 months ago creatinine exam, you have no clue about that. So here is where the patient changes, the anxiety changes during this first consultation. It's very important to change this first moment. And I don't know if I want to do dialysis or not. No, calm down. You don't need to do that. And the experience changes when you are comparing venous blood drawn for a capillary blood. This experience changes when you need only 1.2 microliters from 1 milliliter at least of venous blood. The patient is more prone to do only a puncture on their finger than collect the venous blood at the site. Other moment, it probably will be one of the most important moments, is the home self-testing. We are well used with home self-tested with glucose meters. It's changed our way to look diabetes with the home self-testing. In this study over here, the point-of-care devices from creatinine are put on the hands of post-transplant patients. And this post-transplant patient measure the creatinine in his finger every day. Some maybe problems arise because normally patient with a slight level up of the creatinine result, patient get a little bit anxious, but at the end he understands it's not the result of this day, it's the trending of the creatinine that will change if he will be asked to return to hospital for an early diagnostic of early graft rejection or not. And we have to understand probably most of us have keep the patient in the hospital just to monitor the creatinine function after transplant because we are a little bit worried. And this can be changed, and is very costly. And when we say about point-of-care device where the laboratory doesn't reach, it's important to mention this NGO called La Isla. La Isla is an NGO from Holland, from Netherlands, and it's stated in Nicaragua and other countries, and they measure the creatinine in heat environments. So they wake up, I have talked with the lady over there several times, and they wake up 3 o'clock in the morning, goes to the sugarcane plantation in Nicaragua, El Salvador, or in Sri Lanka and other places, and measure at the point of care, at the actual environment of the worker, the creatinine after every 6 months of the same patients over there. That was very important because they evidenced us about what we can at the first called Mesoamerican kidney disease, and now we are calling heat-related chronic kidney diseases because we know now that it's not a Mesoamerican thing. So this is very important. This has changed the way we see these workers around the world, and this is very important. Another project that we are dealing this is in the pre-hospital. I have this project in Guayaquil in Ecuador with the fire department over there, and the fire department over there has this luggage with the creatinine, cetones, lactate, glucose, and hemoglobin. And this motorcycle goes first before the ambulance to see if the patients need a medical ambulance, in what complexity this patient has. In Guayaquil, there's no dialysis in every hospital, so they have to direct the patient for the right hospital. It prevents the time that the patient will be losing in some ER or something. And probably we are calling, this is precise. I'm a little bit against comparing oranges and apples, because we are here comparing a blood sample, a venous blood sample, centrifuged in the hands of a technician in the central lab. And we are comparing with a single drop, total single capillary drop, and even we compare with this result is validated, is correlated, and is very, very, very correlated between them and precise. So it's important and validated. But one thing normally arises when we are not in the control environment of hospital, when we are measuring outside the controlling environment. One of the things that I learned hardly is when you are measuring this creatinine after a cooked meat diet, the creatinine can vary a lot. 2 times, 3 times. The glomerular filtration rates can fall down 20% or more after 1 hour of the cooked meat. These 2 papers over here addressed very, very, very goodly these two samples. But in the health patient, of course, as in glucose tolerance tests, when we do this with glucose, we have the same. The creatinine level returns to normal in 4 to 6 hours. We have to understand that. So probably when you are pushing this point of care creatinine in a bar with a guy that you know, let's see your creatinine level, and it comes 2, and you get worried. Take care and look what the environment do and what is the interferences over there. But besides this can and easily will change everything. The point of care creatinine goes further, goes where the laboratories don't reach, it goes where the time is important, when the volume sample is important, and after all, goes where the patient experience is important. And then I think at the end, it's what matters. Thank you. Thank you very much. If you need some further information, please scan me. I will be over here. Thank you, Doctor.
Please. So thank you very much. I think we have a lot of food for thought. I would like to start asking you a question concerning the concept of point of care. I'm particularly interested in the possibility for monitoring in home therapy or limited care therapies area. But if you do for limited therapy care, you have a point of care that can serve for multiple patients. But if you do for home therapies, you only have for one patient. So do you think this could be still economically feasible and manageable?
Sure. We have this, and of course, when you see the glucose meter 40 years ago, it was not so affordable than this is nowadays. Well, I think this is the change that's occurring. And it's not only with lactate or with creatinine, as I said, it's another bunch of things that you can change. And I think one of the trends of the health system is to put the patient outside the hospital.
True.
And that's what everybody wants. And I think it is the future. Probably in 40 years, when one guy will talk with his son and said, "Father, what is a hospital?" Maybe in 40 years there will be a question like that.
Yes, but in this transition phase, do you see it feasible for somebody to bring your device at home, for example?
Yeah, of course there is a issue about registration in the health regulatory system. There is different registration for self-testing and for hospital and professional testing. This is an issue that is changing. It's already changed for lactate meters, for example. Lactate meters are being used for sports and on. And this is changing for other more specific exams. I think there is a concern about the patients with that result, what they will do. They will go to the doctor or go to the Google. That's
yes.
the main thing.
Yes.
Yeah.
Yes, that's a very, very important. In other words, to gather the information is important. What you do with the information is very. Yeah, you had the question?
I don't think it allows.
Yes.
Oh,
It works.
Yay. So my question is, point of care, out of hospital, point of care at the pharmacy. Who's going to pay for it?
I think at the end, the system will see that it is affordable. If you have a early graft rejection, you have detection of a low glomerular filtration rate that could be a high risk for nephrotoxicity. The system will see that this will be affordable, but where the system is now seeing this is affordable, talking about medical imaging. In 5 years ago or 10 years ago, it's unimaginable to have this device in a medical imaging clinic. So it's changed. So it's going to change it.
Okay, Thomas?
Yes, Thiago, based on the data you displayed, do you think we need to increase the magnesium level in the substitution fluid bags in the Baxter protocol?
Thomas, I don't think, I am sure. So I think the whole industry will be changed, because now we are seeing that if you measure ionized magnesium, almost all patients on citrate anticoagulation have low ionized magnesium concentration. The same goes for phosphate. Remember, before solutions, they didn't have phosphate, and we were just ignoring hypophosphatemia. And now we know the bad outcomes in patients with hypophosphatemia. So I think like the companies will start producing bags with higher ionized, higher magnesium concentration.
Okay, we still have time for one question, probably. Yes, please.
I would ask as well, Thiago, like, do you think that this magnesium is just another electrolyte, and after magnesium, are we going to look to other electrolytes and thinking that we might put something, maybe a more concentration? And I would say iron, but there is just all the chemistry other.
Well, for the moment, I don't think we will look for other micronutrients. But I don't know in the future. But I am surprised that we took so long to look for ionized magnesium. We knew from the start that citrate would chelate magnesium, and we think it's okay to have hypomagnesemia. And yesterday, Jean-Louis Vicenza mentioned about chloride. It's not okay to have hyperchloremia. So I think either it's not okay to have hypomagnesemia.
Thank you.
All right, and we have no question from remote. I was just checking. So thank you very much for organizing this symposium. I think it may be a kind of a starting of a new model, of a new way of thinking, and the idea of having point-of-care measurements may definitely improve our practice. So thank you, Thiago. Thank you, Rubens, very much.